Welcome to the Cardio Ohio podcast, a production of the Ohio chapter of the American College of Cardiology. This is Kenny Graywall in Columbus, Ohio.
This is Ben Allencherry, Cardiovascular Imaging Fellow from Cleveland, Ohio. More information on the podcast, including past episodes, is available at ohioacc.org.
And now for today's episode.
All right, everyone, welcome back to the Cardio Ohio podcast. This week, we have a very special guest, Dr. Sagar Kalahasti from the Cleveland Clinic, from the Advanced Imaging section and an expert in aortic disease. Dr. Kalahasti was on the most recent iteration of the 2022 aortic guidelines, which we will include in the show notes. Dr. Kalahasti, how are you doing?
I'm doing great. Thanks so much for having me.
Yeah, thanks for coming on. So Dr. Kalahasti, can you just give us a brief introduction about how you got to be an advanced imager and what led you towards specializing in aortic diseases?
Yeah, perfect. So I consider myself a Clevelander now because after my medical training in India, I came to the Cleveland Clinic back in 1998. And God, that sounds so long ago. And I came and did my internship residency as well as cardiology fellowship at the Cleveland Clinic. And I started working in general cardiology after I finished my fellowship. And during that time, I was seeing a lot of aortic disease patients who were coming in for surgery at the Cleveland Clinic. And as a cardiologist, we see them all before their surgical or endovascular intervention. So that really piqued my interest as to, this is something that we don't routinely see very much in our fellowship. But, it was like, man, there's so much of this disease that we are seeing in our clinics. So that's where my initial interest about aortic disease kind of started. And then slowly got into understanding the most common etiologies and the most common patients. We were seeing a lot of genetically mediated connective tissue diseases such as Marfan's or Loeys-Dietz. Loeys-Dietz was not even that well defined at that point in time, but was thought to be something related to Marfan. And so they kind of went hand in hand, my interest with aortic disease and understanding the most common etiologies. And then that got me married into what imaging do we commonly use in aortic disease patients? And said, CT, of course. Yes, echo is used, but CT is like the standard of evaluating the entire aorta, and both in the urgent situation as well as in an elective follow-up situation. And then I realized I need to get more skilled with regards to being able to read CT, to be able to care for these patients better.
I think that's perfect for our listeners to understand kind of how you got to the advanced imaging part and the interest in aortic disease. And for further background, we'll be referring to the 2022 ACCH aortic disease guidelines. So I kind of want to jump in and answer some of the questions that are very practical for our listeners. And the first one we just want to talk about is stable thoracic aortic aneurysms and when to go beyond echo to CT or MR.
Yeah, that's a great question. I think in general, my approach has been to at least get a baseline CT or an MRI, depending on the age and gender of the patient and what history are they coming in to see me with. And that always determines the next steps. And I almost always get some kind of cross-sectional imaging after the initial echocardiogram, just to make sure that the measurements that we are getting on an echocardiogram closely correlate with the tomographic imaging. And after that, if depending on the size, if this correlates well, and depending on the initial size when we are seeing a patient, the time of follow-up, most often, if it is something which involves primarily the aortic root and the ascending aorta, I generally tend to stick a lot with echo. That also helps me looking at their left ventricular function, looking at their aortic valve anatomy, looking at aortic valve dysfunction, whether they have either, if it's a bicuspid valve, do they have stenosis or regurgitation. So echo is like my primary go-to modality in the majority of patients. But at least I get at least one baseline tomographic imaging, whether it's CT or MRI, in everybody that I see. And so having another imaging to clarify the original, dilation or aneurysmal change is very helpful, in my opinion.
So Sagar, this is Kenny in Columbus. I want to just echo Ben and welcoming you to our podcast. A follow-up to that question is serial imaging or serial surveillance. most of us in clinical cardiology now have a lot of patients who we follow who many have just had an incidental diagnosis of thoracic aortic enlargement or aneurysm. We know there's guidelines out there regarding the frequency of surveillance, but I also know in my practice, I have some elderly, frail patients. We have patients who are reluctant to give contrast or excess radiation. So what factors help you tailor the intervals for serial imaging to a given patient so that maybe we can try to minimize imaging in patients who don't need it as intensively as others?
Yeah, great question there, Kenny. So the way I think about it is that, what is the initial size and what is the rate of change of that particular aortic dilation? Let's say, for example, the first time I see a patient, their aorta is 4.3 centimeters. And we do a cross-sectional imaging, for instance, like a CT or an MRI, and it is 4.3 centimeters. Then one of the things that I've learned through practice is that patients are extremely nervous the first time you meet with them because they've already read this up on Google, and then they all come with this idea of a ticking time bomb, right? So in general, I have, always tried to see them for an initial visit, whatever the initial measurements are, within about 6 months, because just to reassure them that this is not what they're thinking, in a realistic fashion, the risk of something bad happening to them. The other point I cannot emphasize enough is that to bring any old imaging that they ever had, whether it's an echo or a CT, because the indications for the previous imaging may not have been looking specifically at the aorta. But having that imaging is really helpful it goes a long way in reassuring the patient that, hey, something was actually there 5 years ago. That's a tremendous amount of relief for the patient. So that's the way I think about it. So just to add to your question about, older and frail and those kinds of people, we don't actually always have to give them contrast, to be honest with you. There are lots of times that we do a cardiac CT without contrast. And if you're purely measuring the dimensions, that alone is sufficient. It's very different if somebody has a dissection, you want to see what's happening with the true lumen and what's happening in the false lumen. Their contrast role is much more. But if you're purely looking for a size of the aortic root and ascending aorta, you could actually do a gated non-contrast CT like we do for a calcium score. And you should be able to get the dimensions without worrying so much about contrast. The next point is, how about radiation, right? That I think is if somebody is a younger patient, like in the 30s or 40s or 50s, you're thinking about their lifetime risk of radiation. And that's where I think having echo as your main tool helps in minimizing that exposure to radiation.
I think the key message is that you do want to tailor the surveillance plan to the patient and their age and comorbidity. And I think it's a great reminder that we don't have to use contrast in every situation. I know we have some of our imagers here who also will sometimes even do MRI without contrast for the same reason. Just to turn attention to medical therapy briefly, I know there's not a lot of literature, at least evidence-based literature about specific medical therapy, but I know in these guidelines, they do kind of point out, especially in Marfan's patients more than others, there clearly is a role for, beta blockers or ACE. Are there any tips you have in your own practice for initiating the meds or even deciding when medical therapy is needed in these patients?
Yeah, it really is a good segue into talking about the medical management. I think beta blockers have been like the gold standard that's been established for many, many decades now. And I think more recently, ACE inhibitors, yes, but I think there's been a lot larger role for the angiotensin receptor blockers based on a few studies that have been done specifically in Marfan patients. And the pediatric heart study published many years ago in New England Journal of Medicine, and then multiple other meta-analysis that looked at other ARBs combined, something like irbesartan, have been looked at in Marfan patients specifically as an extension of that benefit in those patients. I've routinely used losartan in other patients. So as an initial treatment, I think the most important thing to look at is that, what is their initial presentation? I see a lot of patients who are quite athletic, and this was found on, let's say, a calcium score, for instance. And they're otherwise performing very well and their exercise capacity is very good. Younger age patients, I'm a little bit careful about starting them on a beta blocker because some of them are already bradycardic. They come in their 50s heart rate, or younger patients in their 20s or 30s. Sometimes, you worry about the side effect profile of a beta blocker with fatigue and erectile dysfunction. So I take those factors into consideration as to which would be my first drug in the patient. And definitely I use angiotensin receptor blockers quite frequently. And most of the time it's either losartan or irbesartan because those have been studied. Are there patients that I have to use more than that? Yes, there are a lot of patients who have purely hypertension as their major comorbid condition. So I always incorporate these two medications. And in addition to that, they may need to be on others too, like going back to our usual hypertensive meds, like a diuretic based regimen or calcium channel blockers or direct vasodilators. So I have used all of those. But in general, the two most common meds that I use is beta blockers and angiotensin receptor blockers. And I titrate them to the maximal doses possible before I start any other or a third medication or anything like this.
And Dr. Kalahasti, just a practical point: if you're seeing a patient who is on an ACE, do you actually try to switch them to an ARB? I saw the strength of recommendation isn't terribly strong. Yeah, what do you actually do in clinical practice?
If they're tolerating it very well, then I have not routinely changed it. I have continued it in those patients. But if never been exposed to any prior medical treatment, then in general, I've gone to an ARB.
Okay, perfect. So I think that's probably the limit of the medical therapy. Now, if you get a patient in your clinic who has a new diagnosis and you have to kind of traverse the waters of genetic testing, I know this can be a podcast in and of itself, but a lot of the recommendations about, identifying the proband and then going down through cascade testing are somewhat nuanced. But do you have an easy framework for genetic testing in patients who first we can start with in relatives of patients, and then maybe we can talk about a patient who comes to you with no diagnosed aortic disease, but maybe their relative had it. So do you have a framework that is kind of simplified for the audience?
So I think, if you're seeing somebody who is, below 50 years of age, for instance, and they've been diagnosed as having an aortic dilation, for instance, whether they got, some kind of a screening test, whether it's lung cancer screening or they have had, calcium score or something like that. In those younger patients, family history is probably the most important thing that you can get during that first visit, is to dig as deep as possible in trying to explore what their family history is. And if there's any other first-degree relative with a family history of an aortic disease, I generally send them to genetic testing. And that involves actually not just the testing part, but just actually meeting with a genetic counselor, because sometimes things that we don't really think as being, important in a family history, genetic counselors are extremely good in trying to dig a lot deeper into that. Again, another important factor. Sometimes you get patients who've had a relative with a sudden death, and then they are diagnosed with an aorta, which is like borderline, like 4.1 or 4.2 centimeters. There also, I tend to be much more proactive, keeping in mind that we only know, yes, the genetic testing panel now has expanded from a few genes many years ago to now we almost test for 38 to 40 genes. The way I think about it is that I feel that most of the aortic disease is genetic. It's just that we have not found all of the possible mutations that is actually causing people to develop genetic disease or aortic disease. So it's, if somebody goes through the pathway and, meets with a genetic counselor and then they get their genetic testing done, let's say their panel comes back as negative, that doesn't exclude that they don't have a genetic disease. So there, the next step is both simultaneously happening. Not only the genetic part is also, I recommend all the first degree relatives to undergo some kind of imaging follow-up, whether it is echo to start with, and if there's any abnormality in echo, then escalate it to a CT or an MRI. So it's the way I think about it is it's like two different pathways. One is to look primarily at genetic testing, but also simultaneously have their first degree relatives screened for aortic disease.
So Sagar, in that framework, then most patients above 50 who have more, say, hypertensive associated aneurysms, it sounds like genetic testing would still not be used in a majority of those, and that you would focus more on maybe first degree relatives when it does look like there's some kind of familial basis.
True. Let's say the only exceptions for that, Kenny, is that, let's say, a 60-year-old man comes in and he says, my brother recently had an aortic dissection and I am here for that. And I'm worried about my children and worried my grandchildren. So again, it just comes down to the individualized decision-making beyond that age group. But I don't say that, oh, it's not going to be a value, because I have seen some patients where we diagnose them as having these familial aortic, aneurysm pathways, or now it's being called as heritable thoracic aortic disease. And those patients have a familial pattern of genetic mutations where they don't have a phenotypic feature like a Marfan or Loeys Dietz, and their only manifestation is aortic dissection. But in general, I think that if somebody is younger age, then I think there is probably a little bit better role for genetic evaluation.
Yeah, that's great, Dr. Kalhasti. So to distill it down, it's depending on age, use imaging plus genetics to kind of guide you in the screening process.
The family history of the patient
and
as being
families.
one of the major factors.
Perfect. And kind of leading from genetics and screening of relatives to now management. And I think one of the main recommendation changes in these guidelines was the threshold for surgical intervention for root and ascending aortic aneurysms from 5.5 to 5, and even lower if you have some specific heritable aneurysm diseases. From your experience at Cleveland Clinic as well, while being on the writing committee for the guidelines, what has spurred this change?
So I think, just broadly speaking, so I think the things that have changed is that, we have got other tools rather than just the aortic size itself, right? So we're now indexing the patient's aortic size to their, if you take the cross-sectional area of the largest segment of the aorta to the patient's height, or we are doing an aortic height index. So I think there's been some refinement with regards to risk stratification of these patients. The second part is the low risk of surgical intervention, right? So that's the second part that has changed, over the past decade since the first guidelines came out. And then the third part is that the long-term outcomes of elective repairs have also been significantly better, particularly like a valve-sparing aortic root replacement. For Marfan patients, their first surgeries used to be always like a Bentall type procedure with a mechanical valve, because most of these patients were younger. So we were committing them to lifelong anticoagulation. So along the way, when the valve-sparing root replacement came, and people wanted to wait to see what their long-term durability is, and it's been very good. I can speak in centers of excellence at Cleveland Clinic, the likelihood of reoperation for a valve-sparing root replacement remains very, very low at 10 and even longer follow-up. So these constellation of factors have really helped us in defining, are there patients that we should be intervening on earlier, right? So that's the way I think about these things, and that's where the thresholds have come down. The other thing also is the role the imaging plays, because you are able to get excellent imaging, and you can easily understand the differences between studies and how quickly something is changing. And we incorporated that by giving a proper definition, because as we know, between studies, sometimes you can see a significant variation in measurements, and that can create panic. And I think that was one of the things we made sure that we put it into the guideline document, is to look at what is a rapid growth. What would you consider as a rapid growth? And then one of the things we clarified is that if it's more than 0.5 centimeters in 1 year, that should be considered as a significant change. This, I'm not talking about dissected aortas. This, I'm talking about intact aortas, right? So, and then the other thing is that if you have consistently 0.3 centimeters over 2 years, then that's also considered as a significant change. So when you put all of these things into consideration, I think, surgery at the lower threshold seems very, very reasonable. What never makes it to guidelines is patient anxiety and patients wish to have something done, right? Because some people have had their lives upended completely from the time of diagnosis. And despite your best efforts, so I think the guidelines did, in my opinion, we had a very robust discussion about all these things. And we wanted to give a little bit more pragmatic and more practical approach, and saying that, if you go to a big center of excellence, it's very reasonable to be doing at smaller sizes than just saying it has to be a certain level for you to have a surgery.
And I would echo that, in my 20 years of practice, it's amazing the spectrum of patient you see, from those that want to jump right on something and get it fixed immediately to those who want to avoid anything if possible and are willing to accept some uncertainty. So I'm really glad these new guidelines do offer some nuanced criteria that can be individualized, because I think sometimes we didn't always have that. Since you do talk about your center there a little bit, one question that always comes up is when does a patient need to be referred to a center of excellence or a heart team? Is it once they actually meet the criteria for surgery or intervention, or do you feel like there might be patients who are just being monitored serially that could still benefit from establishing a relationship at a center like yours?
I think depending on the initial size when they start with, let's say, they're seeing their local physician, local cardiologist, and their size has been very stable at, like, say, 4.1 or 4.2 centimeters. I think they can continue to follow with their physician. But anybody with rapidly changing or significant family history, or somebody who wants to have a surgery at a smaller diameter, for instance, you don't want to have them undergo surgery at smaller volume centers because, again, going back to that point about valve sparing, you don't want to be in a center where the surgery gets done when they get their valve replaced, when there was no need for the valve to be replaced. So all those can be important factors to consider. And some patients do prefer to come and establish with the surgeon, and they just want to see a surgeon, talk about it, just to kind of understand what's coming down the line and how well they can prepare for that. So I think, just to give a broad points, I probably would say, I mean, of course, if somebody gets diagnosed the first time, it's at 5.2 centimeters, we would like to see them sooner than later. But if those patients who are, let's say, 4.5 to 5 centimeters, they could come and see us for an initial evaluation and establishing with somebody, and they can visit us maybe once every 2 years if there is stability.
Yeah, that's really helpful, Dr. Kalhassi. Speaking in the management, we've been kind of focusing on chronic aortopathies, so to speak, or thoracic aortic aneurysms. Now, just to switch a little bit to acute aortopathies. And looking at the guidelines, not much has changed as far as like type A dissection.
Mhm.
But I do want to kind of get your thoughts on how you put into some sort of mental framework the intramural hematoma and the penetrating aortic ulcer, and how they kind of go hand in hand with type A aortopathies.
So as far as the type A, the classical, dissection and involving the, ascending, they still go to surgery, right? So that's a standard accepted. I would say the same thing applies for type A intramural hematoma. So they should go to surgery as the initial management. In general, we don't see so much of an ascending penetrating ulcer, right? So it just doesn't happen as commonly, just purely based on their embryological origins. I think they generally tend to occur more in the distal arch to descending to abdominal aorta. We do see a lot of incidental penetrating ulcers in a lot of patients who go through CT. They have very atherosclerotic descending aorta and abdominal aorta. You see these valleys and peaks inside their aortas with some undulating type, atherosclerotic plaque. So those patients, you don't necessarily have to think about surgery, but they can present acutely, particularly if they come with an arch rupture or a descending rupture. So that's where, endovascular stent treatment would be very helpful in those patients. So if you look at the type B dissection, I think one of the things that the new guidelines have done is put in an increased role of endovascular approaches, because I think that's, again, another area that has really changed a lot in the last decade. And aortic specific mortality is actually better in those patients when you intervene with an endovascular stent early on. So to go back to your question, so I think if it's a type A intramural hematoma, the treatment is still surgical. And in general, we don't see penetrating ulcer there. But if somebody presents with a penetrating ulcer or rupture or a type B dissection, then you generally tend to look at an endovascular approach to those patients, along with the medical treatment is still the same, right? You still do impulse control, but what strategy you use depends on the location of that. And I just want to add that there is more, based on some of the studies that are actually done at the clinic by Dr. Roselli and their team, is to do more extensive repair at the initial surgery itself, which is something that has been pioneered here, which is the branched, single anastomosis frozen elephant trunk, or a B-safer approach, where you do an ascending aortic and arch repair, and then you do a descending repair at the same time, while taking care of the arch branch vessels coming from the acute situation. So that's being studied now. So we will know probably 5-10 years down the line, did we make a meaningful difference with regards to their long-term aortic remodeling? I think that's definitely something very exciting to look forward. At the same time, if the patient goes to a smaller center, right? So not everybody can get to a large center. There is still role for and limited ascending aortic grafting as a tool to make the patient survive. So your patient selection becomes important as to who is that patient that you can do more extensive repair compared to which patient you want to do a limited repair, and also which center you are in.
Yeah, that's very insightful. Thank you. So is the endovascular approach, even within thoracic aneurysms, is that continuing to grow at your institution? And what do you see as the future for endovascular options versus surgery?
So I think the field is definitely moving more towards the ascending aorta. So there are now branch devices that are being made by many companies looking at arch replacement. They actually have separate branches coming from the native graft and how you can use those to treat the arch branch vessels. At the same time, you're fixing the aortic arch. And Dr. Roselli did a trial looking at emergency for those patients who are not operative candidates for a type A dissection. There's a trial that looked at the feasibility of doing an emergency stenting in the acute descending dissection patients. And the initial results seem pretty promising. But again, unless it's applied in a wide variety of groups and, long-term follow-up, and, the way I think about it is it's like TAVRs, right? So when the TAVRs first came in, they were tried in people who are inoperable. And when you establish the safety and feasibility, then you go down to the next level. So I think the same kind of innovation, I think, is going to happen with type A aortic dissection, where we can actually treat more patients who are not operative candidates, that you can actually do an endovascular repair initially just to allow them to recover. And if their health is otherwise okay, then, maybe you may be able to use that as a bridge to more definitive repair for sure.
I just want to say thank you for everything. We talked a lot about the genetics, stable disease, acute disease, med treatment, surveillance. And I want to thank you because being a guideline author on obviously a very influential document is an amazing feat. I'll just remind everyone that the 2022 guidelines we'll have in the show notes, and it talks a lot about other things as well, such as pregnancy and aortic disease. So make sure you reference that. But just since we have a primary author here, Dr. Kalahassi, what was that process like, and how does it feel having a finished product there?
Yeah, it's actually very humbling and very honorable, experience, in the sense that, usually guideline authors are, people are considered as experts in the field. It doesn't always have to be research. It could be very clinical, and their peers recommend them to these guidelines. And that's how I got recommended by some of my colleagues who are ACC committee members. And that's how I got the opportunity to participate in this guideline. And what I will always tell is that even though the process sometimes is time sensitive and time intensive, it's a humongous educational opportunity, in the sense that you get to talk to so many experts in the field across the country, and they all are doing great work. And to listen to their perspective from their institution standpoint is very enlightening. Although we want every patient to be treated in a big center like Cleveland Clinic, so the guidelines are a document that anybody across the country, not just in USA, but across the world, will be able to look through these things and say, does this make sense? Is this pragmatic, or is it just catering to the only certain institutions where we cannot reproduce these things? So I think that has been the most valuable experience. And I'm very happy and thankful that I've got the opportunity to participate in a document like this.
Yeah, Dr. Kalahassi, just want to say thank you so much for all your contributions, and thanks for sharing both the factual parts and also just your experience, because it's a pretty awesome feat that you just accomplished. So thanks a lot on behalf of my co-host, Dr. Kenny Graywall, and we appreciate you coming on the podcast.
Thank you so much for the opportunity, and please feel free to reach out to me if any questions come.
Thank you for joining today's podcast. For more information about the speakers or the topics, please go to ohioacc.org.